So, good morning, good afternoon, good evening, based on where you are joining us from, and welcome to today's webinar. My name is Laura Ceci Galanos. I am the Executive Manager of the World Stroke Academy, which is the educational platform of the World Stroke Organization that provides stroke education to health professionals worldwide. As always, it is with great pleasure that we are hosting this webinar, this educational activity on the future of stroke treatment, insights from AI and emerging technologies. We have exceptional speakers that will be sharing their expertise on the topic. But before we do that, as per usual, very quickly, a look at some of our housekeeping rules. We always welcome your questions that you might have throughout the webinar, but we kindly ask you to use the Q&A box for those in your Zoom control panel. So not the chat, but the Q&A box for questions, which will be addressed in the end in the Q&A discussion. You can, of course, use the chat box to say hi, tell us where you're joining us from today, or leave your comments. A reminder also that the webinar is recorded and that the recording link will be sent out to all of you via email shortly after the webinar. It will also be uploaded on the World Stroke Academy site and the World Stroke Academy YouTube channel, so you will get a chance to rewatch it once it is uploaded. And lastly, we kindly invite you to fill in the evaluation survey at the end. It really helps us when you share your feedback. And this is also the place where you can claim your certificate of attendance. This is not a CME accredited webinar, but you can still claim the certificate of attendance there. Now, without further ado, let me introduce today's chair and also our moderator, Professor Gisele Sampaio Silva. She's Professor of Neurology at the Federal University of Sao Paulo and Head of Neurology Clinical Research at the Albert Einstein Hospital of Sao Paulo, Brazil. Gisele, thank you for being here, and the floor is all yours.
Thank you so much, Laura. It's a great pleasure for me to be here. And I welcome you to the session that is focused on the integration of technology and innovation in stroke care. Today, we are joined by three internationally renowned experts who are driving change across the continuum from pre-hospital to advanced neuroimaging and integrated stroke network. Together, their work represents a vision of a smarter, faster, and more actable stroke care globally. So it's really a pleasure, and I'm thrilled to welcome Dr. Ona Wu, an internationally recognized expert in neuroimaging and artificial intelligence. Her work has transformed how we detect and interpret cerebrovascular pathology. Today, she walks us through the cutting edge of AI-driven imaging tools, from automated stroke detection to perfusion analysis, and how these advances are shaping diagnosis and decision-making. Ona is an associate professor in radiology from Harvard Medical School, an associate neuroscientist at Massachusetts General Hospital, and the director of the Clinical Computational Neuroimaging and Neuroradiology, and is also a great friend, and I had the privilege to train with Ona a while ago. Thanks, Ona. The floor is all yours.
Hi, thank you, Gisele, for that kind introduction. And I'd like to also thank the organizers for the kind invitation for presenting at this webinar where I'll be discussing AI applications on neuroimaging on cerebrovascular diseases. In particular, I will be focusing on stroke. So here are my declaration of financial interests and relationships. Okay, so I will be discussing today how AI neuroimaging applications can help stroke management all the way from in the different phases of stroke care, from the pre-hospital to the hospital care and to recovery. So I will start by discussing how AI can help while the patient is in the hospital. So we already know that neuroimaging plays a critical role in the acute management of cerebrovascular disease. So for example, primarily it can be used in the diagnosis to differentiate between patients who are presenting with intracranial hemorrhage or patients with acute ischemic stroke. In addition, we can see that neuroimaging has a critical role in treating patients who arrive later than the traditional 3.5 to 4 hour from last known well. So, for example, the Diffuse 3 trial showed that using CBF Tmax mismatch, you can actually treat patients with endovascular therapy between 6 to 16 hours, whereas the MR Witness and Wake Up trial showed that you can treat patients with intravenous therapy using a diffusion flare mismatch from 4.5 to the 24-hour window. So a question that we'll be discussing today is, how can AI further enhance in-hospital patient management? So some of the ways in which AI has been used is in automating abnormality detection, such as doing automatic ICH classification, generating volumetrics, automatic calculation of aspect score, automatic detection of large vessel occlusion, CT perfusion measurements, estimation of collateral scores, as well as mismatch calculations. It can also be used for optimizing workflow for radiologists, selecting which sequences to use and what data to acquire based on patient presentation, as well as improving image quality and resolution. So I'm just going to do a very quick, like 1 minute overview of AI basics of how segmentation prediction occurs. So basically you can do it either on a single image or use multiple images. And basically what you are looking at the image characteristics across multiple imaging modalities. And based on those multiple different imaging characteristics, you can transform the values from these multiple variables using a function to estimate, likelihood of infarction or hemorrhage or whatever your task is for trying to make that prediction. So this is an early example from way back in 2001 when we tried to predict likelihood of tissue infarction based off of acute MRI findings. Classification is basically taking the input images and putting it into an architecture that has been trained off of hundreds of thousands of samples and making a classification. So, for example, this is an example of a whippet, and the output tells you what's the classification of what type of dog it is. Not just as a simple dog, but it says, hey, it's a whippet versus a greyhound. So you can similarly do this for images and say, okay, what's the likelihood that this is a stroke or versus an ICH? And so this particular architecture I'm showing is AlexNet, but of course there are multiple architectures available that can be used and have been used for medical imaging applications. So, for example, here is a case where they used one of these architectures for doing ICH classification. And so, for example, they feed in these 2D images, and the output would be, the type of ICH, whether it's an SAH or IVH or different SDH. And in addition to just generating the classification of what type of ICH it is, it also generated what's called an explanation map or attention map that tells you which areas in the images the algorithm focused on for making its classification. And so this will lend more credence and confidence for the clinicians in making sure that the generated classification is accurate. Another application is using, of course, ICH classification in addition to volume. So these are, several studies which shows that you have excellent agreement between the segmented ICH volume with the actual manual outlines, and they also showed that it also outperformed your traditional ABC over 2 estimates. And again, with better identification of volumes, you can then further use that into as a more accurate imaging phenotype to use in further downstream models that are used to predict outcomes as well as treatment effects. Another one that's used for patient triage for deciding whether or not it's safe to treat patients with either endovascular treatment or with IV TPA is the aspects calculation. So the aspects calculation is based off of your non-con CT scores, and this is how one would traditionally score it manually. You would take a look at these various slices, and then for every region of hypodensity identified, you would take off a point of, so you start off with a score of 10, and then you minus 1 point. And patients with very low aspect scores are traditionally considered not likely to benefit from mechanical thrombectomy. There are now numerous different software algorithms and applications that are available commercially to automatically calculate the aspect scores. And it's been shown that with these automated calculations, you have improved inter-rater agreement and also reduces interpretation time using these automated scores. Other applications have been automated large vessel occlusion detection. And again, there's several software commercially available applications out there that can basically identify where the large vessel occlusion is. So here you can see on the image on the left, in the highlighted red boxes are the areas identified where the large vessel occlusion occurs. And then here in a separate study, they showed that using these automated algorithms that you basically can reduce time for treatment for endovascular studies. So again, better workflow, better EVT times, better patient outcome. And again, for segmentation, there are lots and lots of programs, as you can, so as I introduced very early on, one of the earliest applications of AI in stroke care has been for segmentation. So this is just one of many. And if people are really interested in looking and purchasing an application for the institution, there's this excellent review article by Chanda Butler et al. That was in 2023, where they identified 22 different FDA AI-enabled software packages. And they also have a listing of all of the pluses and minuses for the different algorithms and the context of use as well. So I'm not going to bore you all by going into 22 different software packages. So that's a nice reference. So now I'm going to move on to protocol automation that I discussed earlier as an application. So basically, by doing this protocol automation, it actually ends up improving quality control. So they found in this one study that basically they did a simulation where you would input the patient presentation, and then you would evaluate the accuracy of what the AI natural language model or LLM would do in terms of deciding which sequences to protocol. And they found that it actually performed, with 95% accuracy. And in the remaining 31 cases, they performed 92% accuracy. And the benefit of these automated techniques is, again, it ends up kind of standardizing care, improving generalizability, and also making it much faster. And same thing on if you're trying to protocol an MRI protocol, you see again that using these different models, you can end up doing an automated sequence selection. Also, again, saving time for patient workflow, so that way you don't have a patient having to be sent back into the MRI scanner. Other uses for improving for AI use is basically for denoising. So basically you can have a very noisy acquisition. For example, if you only have a 1.5 Tesla scanner, you can try to increase its SNR by using denoising algorithms. You can also use super resolution. For example, you don't have time to acquire that high resolution 7-minute MP range. So again, you can do a lower resolution, and using generative adversarial networks, you can end up what they call super resolution sequences. You can also do, again, there's an example of called synthetic imaging, where you can take low signal to noise arterial spin labeling and get high signal to noise, which takes 8 minutes. So the high signal to noise basically just takes about extra averaging. Another technique people have used is converting the very hard to read CT scans, and they try to convert it to your acute MRI scan. So here's an example where they have the real DWI, and then they generated a fake DWI from the initial CT scans. And in fact, they even simulated the artifacts, the susceptibility artifacts on the DWI scan. Other applications is that you can make it faster. So you can see here you have a 3-minute MRI scan, and you can use that to actually get very similar results from your standard, 30-minute acquisition. So I'm going to go very quickly how you can use it for pre-hospital stages, which will be the last speaker. So basically, people are now trying to move imaging to point of care, so that way you can treat patients much faster but from the EMS. But in order to do that, you need better neuroimaging to help with the diagnostics. So point of care examples of imaging are mobile CT units, as well as portable MRI scanners. So of course, similar to how you can improve low SNR data in hospital, you can do that also with the mobile CT. So you can end up improving the quality of the signals that you're getting. You can also use it for doing automated large vessel occlusion, as you can see in this study, which showed that they were able to do automated large vessel occlusion and hence then triage the patient accordingly to a hospital that specializes in mechanical thrombectomy. There's an example of additional different algorithms to improve low SNR CT scans. Mobile MRIs, the same thing. There's a lot of potential with portable MRI scanners, but its weak points is that it still needs some improvement in terms of the signal to noise and quality of the scans. And so using deep learning and other AI algorithms, you can actually improve the signal quality. Lastly, we can also use AI algorithms to help in patient recovery. And so you can use it for doing outcome predictions, either on the tissue basis or on the functional basis, by being able to predict what the future stroke deficits and potential that can help guide stroke rehabilitation. In addition, and lastly, you can also use it to predict stroke recurrence. So again, using segmentation algorithms, instead of doing segmenting current tissue that's infarcted, of course, you can predict future infarction by using the same methods as described before. You can also use, these are all various different takes of fancy architectures. You can also use it to predict hemorrhagic transformation, hematoma expansion. You can use it for doing virtual crossover trials, predicting, okay, what outcome would happen if I gave it treatment A versus treatment B. So this is an example when we applied it for normal baric oxygen therapy. You can use it to predict functional outcomes using a combination of both imaging as well as table formats. And so this is an example of using a DAFT score. And so here, this is, for those who are interested, this is your DAFT architecture. You can also similarly use it to predict functional outcomes. And this is one thing that's interesting is here they showed that the AI algorithm significantly outperformed neurologists. And they said that when they combined imaging with the clinical data. So, okay. And lastly, you can also use it to predict motor outcomes using combined imaging and clinical data. And here, this is a transition over to Carlos's presentation. So they basically combined large-scale patient data. So this is data that you collect from standard health registry or insurance claim forms, and they were able to use that to create this virtual human model to predict outcomes in 4 different randomized clinical trials of CADs. And what the outcome they're trying to predict is stroke occurrence. And they found out that they were actually able to predict the trial results in 3 out of 4 trials, which is pretty impressive. So anyway, potential pitfalls. Don't want to predict sentient AI, right? That's bad. And we already see videos on the internet of robots attacking humans. Again, things to consider when looking at AI models and deciding what you want to purchase is how are the models trained? How do they perform? Are the results explainable? And also you want to see whether it meets the principles of ethical AI use in society. In conclusions, though, there are many opportunities for AI to enhance stroke care. And to echo, Gisele's intro, AI offers opportunity for faster, better, and more efficient care. And I want to acknowledge all of my collaborators, especially Jihao Wang and Dylan Wu, for helping this presentation side. And feel free to send me any questions. I know I went very fast. Sorry about that. Thank you for your attention.
Thank you so much, Ona, for this great presentation. It's like actually seeing how stroke care is going to be held in the future. So now for me, it's a pleasure to welcome Dr. Carlos Molina, who needs no introduction, but he leads one of the most forward-thinking initiatives in Europe, the Umbrella Project. So this program is not just redesigning stroke pathways, it's reimagining how we can deliver comprehensive, equitable, and connected care. We look forward to learning with him. Dr. Carlos Molina is the director of the Stroke Unit and Brain Hemodynamic Hospital at Valdebrón, Barcelona, Spain. Please, Carlos, the floor is yours.
So thank you very much. Thank you, Gisele, for that kind introduction. So we are going to talk about in the next 15 minutes about a transworthy AI solution for data integration, data analytics, and decision making is the Umbrella Project. So this is my disclosure, which is related to this talk. So I'm the PI for Harmonics, Trust Stroke, and Umbrella projects. So as you know, stroke is a very complex process of care with different parts that are in some way not well connected, the pre-hospital, in-hospital phase, and then rehabilitation, secondary stroke prevention. Typically, there are silos of information. It precludes the efficient finding the right answer for different questions, different needs that we have at different parts of the stroke care pathway, including what is the best optimal access to treatment, how to improve the early and accurate diagnosis, patient stratification, also identify new therapeutic targets, personalized diagnosis, management and real-time monitoring once the patient is transferred home, and remote monitoring, and also risk prediction. So artificial intelligence have clearly demonstrated in the last year that it's a very efficient support tool for diagnosis, but it's much more than that. Can help us in different ways in acute stroke, not only reducing the workload, minimize human errors in diagnosis and prescription, optimize patient selections for trials, for instance, and most importantly, it will ensure a more effective and high quality data management. But this is the key thing when talking about AI. We need high volume and high quality and then standardized data. It is easy to say that. So it's really complicated to have standardized, harmonized, common data models in stroke. So actually, when we check all the data sets, there is scarcity on data and a lot of bias. So there is a risk of the current bias can be amplified by AI. So there are different solutions that they have helped us to deal with this data scarcity, as mentioned by Dr. Wu before. So the data, synthetic data generation in imaging is also translated into the structured data, so we can create data sets. It's not just a clone of the data, it's just taking the statistical characteristics of the data to amplify the samples and improve the training, the quality of the training. Another problem is the bias. We need to just be focused and let's see with the large language models, we will deal with this problem that the current bias can be amplified because we have already bias in the data, so they need to be well standardized and harmonized. Another issue that is ethically important is the data security and data privacy. This is paramount in stroke care and healthcare in general. So there are two fields that is this data are extremely sensitive, the fintech and healthcare. So in healthcare, in stroke, throughout this life process, life cycle, we need to ensure the data privacy, avoid data leaks or sharing our data. This is the past. It is the end of the story of data sharing. Now we have tools that help us to preserve data privacy, like federated learning that allows a large diverse data sets to be explored independently in a decentralized way, enabling collaborative model training and ensuring data security and data privacy. So it's how it works, federated learning. So you can see in this slide how the data stays in the final device. In that case will be the hospital. So the data stays in the hospital. The algorithms are trained locally and then are further trained. We share the model, not the data. So the algorithm travels from one hospital to other, and in this back and forth interchange of the algorithms. So it feeds a central model that is the final product, the final algorithm that will make the prediction. So we test this hypothesis initially in the TrustStroke project. TrustStroke was a European funded project in the framework of the Horizon Europe project. So 3 hospitals share they standardize the data model, a stroke data model. For the idea was to solve simple questions. What is the risk of early neurological worsening? What is the risk of readmission after hospital is discharged? What is the risk of good or poor clinical outcome? And what is the personalized risk of recurrent stroke? Simple question, but require a lot of data, high quality data, and well standardized data. This slide shows the data flow. You can see you need to work on the efficient capture of the data, not only the electronic medical record, all the clinical records, lab information, but also post-hospitalization information through this digital platform called NORA. So including prompts, prems, and the ranking, all this information is integrated in the hospital, and then a federated learning infrastructure that is here in this slide is used to interchange the algorithm. So the algorithm is initially created in a local basis, for instance, in one hospital, and then the algorithm travels from one hospital to others, feeding a global model. This global model, after first as a retrospective identification of the algorithm and then a prospective validation, is implemented in a digital platform called NORA. So now we are in the second year of this project. So we identified already 2 algorithms for early clinical deterioration and readmission. So we are still need more data to identify the high level of accuracy for the prediction of poor long-term outcome. This is the TrustStroke project that is in part the basis, the foundation for this larger project. This large initiative called Umbrella is an comprehensive, holistic, multi-center approach that goes in the gap throughout this stroke care pathway. So it's a more holistic, including the pre-hospital phase, the hospitalization phase, and post-hospital phase. Is a project funded by the Innovation Health Initiative that includes MedTech Europe and FPIA. So it's 25 partner projects, a large effort that you can see is a private-public partnership. So on the left-hand side of the screen slide, you can see the industry partners. In the middle, you can see the 7 European hospitals involved with the corresponding catchment areas, and the right-hand side, so SMEs and other technological partners. So the aim of Umbrella as the first objective is to integrate and harmonize and standardize in a federated manner. It means we have federated platforms, local platforms, to integrate the data from the pre-hospital stage, the hospitalization and follow-up in local platforms. So this is the kind of data that we integrate. So clinical data from electronic medical records, imaging, ECG, EEG, from all the patients. For this data integration, first, we need to harmonize the data. This is the more tricky part and the main bottleneck. So we need to create a common data model. We need to speak the same language. You can see here the data creation, the different data sets in different hospitals at the local level. So different cohorts are extracted by the local IT departments. So this is then extracted, and then we create an ad hoc common data model toolbox that fits perfectly and match the information extracted by each hospital. So this is the way to create a data harmonization and a common data model, using different approaches, including OMOP and non-OMOP information. The advantages of having this common data model is beyond training algorithms. We can train algorithms, but we can also perform decentralized data analytics. And in the future, it will create the foundation for platform trials, and also to build digital twins, having a very harmonized, standardized, common stroke data model. So once we have the common data model, we need to integrate this information to the local platform. The local platform in this project is provided by Siemens Healthineers. This is the digital platform that allows us the data management at the local level, with data creation, data analytics tools. We can just, with an app that you can ask queries, and in the consortium, in the ecosystem, you can just send queries like, what is the proportion of ICH that experience early hematoma growth in the umbrella ecosystem, and you receive accurate information with that statistical results. So this is the advantage to have this infrastructure, this decentralized infrastructure that can also protect the data, and you can perform decentralized data analytics. So how we train algorithms once we identify the patterns at the local level was using this federated learning infrastructure, same like in the trust stroke. So we are planning to identify up to 10 algorithms throughout the stroke care pathway. The advantage of this project is that we can integrate the data through different data sources. From the pre-hospital phase, we have two solutions: the Stroke Connect, that is the basis for the future digital mobile stroke unit, with a full communication with the hospital, the triangle spoke hub and the ambulance, so we can connect the three settings. The pre-hospital setting is integrated through this application, the Stroke Connect. The stroke pointer is the EEG for the identification of LBO, no LBO, where the validation process. Also the stroke viewer for the automatic identification of LBO and ICH. We have a Neurolytics, which is a dashboard for continuous KPI monitoring. Also detection of atherosclerosis, using different CT technologies, advanced technologies, detection of atrial fibrillation, and cardiac CT. So we know that the data sets for cardiac CTs are very scarce, so this is the candidate for synthetic data generation in this data set. And also the communication platform using solutions. So in the post-hospital care, we will integrate a platform for patient follow-up, which is NORA, and also throughout the stroke care pathway, a UX platform will be implemented to collect all the input from patients and also healthcare professionals. So, and this is the project. We are in the 6 months ahead, so we are already identified the retrospective data set. So now we are digging on identification of algorithms that are going to be tested in a prospective data set, and then the proof of concept. And this is a 5 years project. And that's all done. Thank you very much for your attention.
So, Carlos, this is really impressive. So I think that we go from neuroimaging, and you can see that AI is actually going to change much more of what we do for stroke care than analyzing neuroimaging. Yeah. So I hope you have some time to discuss at the end. Thank you very much. So join us for the last lecture. You're going to have Dr. David Hargroves, who is a key figure in pre-hospital stroke innovation in UK. So his work focused on bridging the gap between symptoms onset and definitive care through technology-driven ambulance protocols and triage system. Dr. David is a consultant physician as the East Kent Hospital University Trust at the England's National Clinical Director for Stroke at UK. Thank you very much, David. The floor is yours.
Wonderful. Thanks, Gisele, for the introduction and the offer to speak. So yes, my name is David Hargroves, and I'm a stroke physician in England, in the UK, and also the National Clinical Director for Stroke for NHS England. I don't have any declarations to mention. A big thank you, first of all, to my collaborators, Angus Ramsey at UCL and Rob Sinister at UCLH, as well as all of the paramedics and nurses and doctors that have been using pre-hospital video triage over the last 4 years in England, and most importantly to the patients that have been part of these pilots and have fed back to us about how they have found it of value. So innovations in the pre-hospital setting. So we've already heard alluded to by both Ona and Carlos about the concept of bringing imaging close to the patient. Now, I'm not suggesting that we're ever going to get to the stage where we can put a CT scan or an MRI scan in the back of a golf cart, but there is certainly potential about bringing imaging closer to patients. My only caveat and exploration of that idea is about the workforce. My own view on this is that we need to get to a stage where it is the paramedics that can actually undertake lots of these investigations if we're going to have a meaningful workforce to do the traveling. What we do know is for stroke, it is a really time-critical condition. So whether it be intracerebral hemorrhage or vascular occlusion, we all seen this graph a million times. So this was, 2 decades ago, and even from the original NINS study 30 years ago, we know the depreciation in value of opening a vessel with time. So it is vitally important that we get the right diagnosis for the patient as quickly as possible if they are going to have a meaningful functional outcome. However, making the diagnosis of stroke is not as simple as one might think. So within England, we, as part of our national audit project through SNAP, we undertook an audit over a month looking at how many patients who referred by general practitioners, emergency care physicians, or paramedics and the ambulance staff actually turned out to have a stroke. And of course, we found that the majority did not have a stroke. What they had was a stroke mimic. So making that diagnosis, although we think as stroke specialists is at times straightforward, the reality is it is a specialized diagnosis, and many of our clinics and facilities have numerous and the majority of patients with a non-stroke diagnosis. So we need to be quick, but we need to be sensitive and specific if we're going to transfer the right patient to the right hospital for that individual. So what does the ideal pre-hospital triage setting look like? Well, ideally, we'd like to be able to select those patients that weren't having a stroke and transfer them to the right place, and that might be actually reassuring them and leaving them at home. On the other end, we'd like to be able to spot those patients with a large vessel occlusion. And so actually, if we've got half the patients with a non-stroke, that probably is only 1 in 20 patients that actually has an LVO that the paramedics phone through. And then, of course, we have the other group of patients that benefit from rapid stroke care but don't have an LVO, and they should go to their nearest local stroke centre. So what is that ideal pre-hospital triage? Well, ideally, you'd put the clinician into the back of the ambulance to actually examine the patient. Now, of course, that isn't pragmatic given the distance that patients live from hospitals. So we need to think of another model. And that's what we have done in England. We've looked at this concept, as other colleagues have around the world, of using video triage, beaming in the expertise, examining the patient remotely, listening to them and the paramedics, discussing with relatives. And so we end up with these 3 scenarios. One where, in fact, it is a non-stroke diagnosis and the patient can be safely left at home, or in fact, it's a TIA and the patient can be left at home and brought into a clinic setting either later that afternoon or the next day. We might find a condition where, in fact, they do need emergency care, but not at a stroke centre, for example, sepsis, and they need to go to their local emergency department. And then finally, probably only half the patients do actually need to be transferred to an emergency acute stroke centre. When we piloted this in England during the COVID pandemic, and we did this at that time because many of our, or some of our services transferred their acute stroke facilities away from the A&E departments to protect patients, but also to free up general medical beds to care for patients in the pandemic. And there were 2 examples in England, so in North Central London and in East Kent, where they did just that. They moved lock, stock and barrel their acute stroke centres to a large hospital which didn't have an A&E. They used video triage to select patients on whether they came to that non-A&E hospital, a stroke specialist hospital, or whether in fact they diverted them to a closer emergency facility or left the patient at home. And you can see from this early work in 2020 that between 35 and 40% of patients could be transferred to a non-stroke specialist hospital, which was often nearer. And in fact, almost 1 in 5, down to 13% of patients could actually be left at home safely. They didn't need to go to any hospital. So suddenly we find that we are being able to be more sensitive and specific with regards to the patients we do transfer to a stroke facility. Over the last few years, we've evaluated those patients that did come through a pre-hospital video triage project. And not surprisingly, for those of you who have used this technology, we found that the access to both thrombolysis and thrombectomy seemed to be speeded up for those patients that you had been able to examine and take a good history. And by the time they got to hospital, in fact, the processes of care improved. Within England, as a result of these pilots, we front-loaded and supported 14 other projects right across the country to look very much at whether or not this was transferable outside of London and the Southeast. Evaluation from my colleague Angus at UCL as part of the photonic work has looked at a stepwise an association with changes in processes of care and functional outcomes. And so we had 4 organizations that over various time points since 2020 have introduced pre-hospital telemedicine. And by comparing their process of care and outcomes with the rest of the country in England, we've been able to demonstrate chronological associations with using pre-hospital video triage. Now, we managed to try and remove most of the confounders with regards to age, sex, stroke subtype, and NIHSS to understand whether or not this did appear to be a superior mode of pre-hospital assessment. Now, the results do demonstrate that for those patients that came through a pre-hospital video triage system compared with the rest of the country at the same time point, there did seem to be an increased association with access to a stroke unit, early consultant assessment, early brain imaging, and also a signal regarding an improvement in functional independence as defined by modified ranking of 0 to 2. If we actually look at those patients that actually had COVID during that period, we found that the improvement in access to better care was even more marked, including functional independence as well. So in summary, in England, we have demonstrated that there's improved sensitivity and specificity in the pre-hospital setting using video triage. And also there appears to be this association with better process of care, which is also associated with improved functional independence. We now have a policy within England that all patients with presumed stroke have a video call prior to transfer to an emergency stroke service. Currently, we have 1/3 of the population that is covered by pre-hospital video triage, and we're hoping to increase that and roll that out nationally very soon. Gisele, I'll stop there and we can take some questions. Thank you.
That's wonderful, David. Now, I think we can come to the most important part of this webinar that's discussing in between us. We have some questions here already for all the speakers, and it was wonderful. It's like foreseeing that we are already in the future. Yeah, we're treating our patients completely different than we did 5-10 years ago. And it's really good to see how our field is moving So Ona, I will start by, sorry to call you Ona, Dr. Wu, I will start by the first question. It's a simple question, but I think it's actually very important who those who are, at the bedside from the patient. So the question is that in cases of very early ischemic stroke, the images do not so much. So how can work up with AI to be able to detect, early ischemic changes for those who are at the bedside? How do you think technology can help with that?
So yeah, I would say, well, the gold standard, I think, again, heavily biased being that I am an MRI person, is that uh, uh, very early ischemic stroke, at least it's been shown that MRI, particularly diffusion weighted imaging, can detect changes as early as 15 minutes in human strokes. So, of course, the challenge is being able to do acute MRI at that early stage. And that's the reason why there is a lot of initiatives in trying to do generative adversarial networks, right? Where basically they can convert that acute non-con CT scan into a DWI/ADC image acquisition. Now, the question is whether a CT scan actually demonstrates that much of a change, because again, they're measuring different physiologic aspects of the tissue, right? So, it may be that you can um, try to combine the non-con CT scans with, say, CTP or some other form of physiological measurements using a CT scan. If the key point is just a sensitive and specific detection of ischemia, not necessarily core, right? Meaning tissue that's irreparably injured, but if you just want to see if a stroke has happened, so you may want to use that type of technology. But again, I would argue that MRI is extremely sensitive, especially if you have access to diffusion weighted imaging. It's extremely sensitive to early ischemic changes within 15 minutes. But of course, I defer to like Carlos and Gisele, who are stroke clinicians here.
So I think that I was fascinated by the synthetic imaging. Can you explain it to us? Because I think it goes with this question very briefly, so that we can understand how it works and how do you think it can, be implemented in the future at the bedside?
Yeah, so with synthetic imaging is basically you train your data, right? Similar to the earlier example I showed where you're doing training. So instead of training of trying to predict a single label outcome, you try to predict the entire image. So this is basically what's called generative adversarial training, right? So basically you train it with your real diffusion imaging as your training input data, and then as you have and what your input data set would be a CT scan acquired within the same time period as the DWI. So the DWI is your target image, and then what you do is you basically train an algorithm where you're trying to say, okay, let's generate a fake image, and then you train another algorithm that detects, oh, can I see a difference between the fake and the real image? And then essentially, once you've trained your synthesizing program well enough such that your fake data detector can no longer tell the difference, that's when you decide that your algorithm has converged. But again, your limitations is that, of course, it's not magic, right? So if fundamentally the data doesn't exist, the information does not exist in your input data, you can't magically say, hey, I can identify, a ischemic lesion when there's no signal in the underlying source data, right? So that's a hard part. Or you can try to, when algorithms go bad and starts hallucinating, of course, you can create an algorithm that says, I always see a lesion there, and if I know it's a left-sided M1 stroke, I'm always going to, because you input that into your model. It's like, hey, do you see a stroke in this M1 suspected M1 lesion? Suddenly, of course, your synthetic image is like, hey, there's a lesion there, right? If all your training data is that.
Yeah, I agree. And when it comes to non-imaging data, also generated synthetic data is tricky because you use the statistical characteristic of the source data, but it's fake data at the end of the day. So the richness of the data, the variability, different sources, for instance, you cannot replace different hospitals, different scenarios, different patients population by synthetic data. So the accuracy in the diagnosis is lower, and also the risk of hallucinations, also if you use large language models, is also higher. Yeah, fully agree. You need to be careful. It's not like magic. You can solve it. You have a scarcity data set. It's impossible to have larger data sets. For instance, we are dealing with cardiac CT data set. It's really scarce now. In the future, will be more common to perform cardiac CT. By now, we have our data sets are very limited. So in that case, we can just use synthetic data generation just to identify the pattern of the potential algorithm for prediction, for instance, for cardioembolic stroke.
Yeah, Carlos, I have two questions in one for you from Vinicius Montanaro from Brazil. So he is asking if the Umbrella project will include a large LLM model at the end, for research. And yeah, and also if the project is gonna work with algorithms on predictions of outcomes. I understood that yes, yeah. If you wanna just add.
Yeah, the second is clearly yes. So in Umbrella, when we planned the study, we were more focused on machine learning type of algorithms, but now we are incorporated, like for instance, for generative AI models for synthetic data, but also in the interaction to have real-time prediction. So you need a sort of virtual assistant to have a real-time prediction using multi-source data. So it's tricky, but for that we need to use a pre-trained data model, which is, for instance, this that are out there, those models that are out there, has to be implemented to healthcare, because by far they are not tested in healthcare so far. So we need to incorporate them. Is planned, not now, now we are relying on prediction based on machine learning, but we will come for sure. But we need a reliable framework. There are some frameworks out there that can be used and implemented in healthcare, but we need to be careful on the ethical concern, the regulatory pathways of this type of technology in healthcare. It's not that straightforward response.
Yeah, and following this, there is another question, and I think it's an important one when we deal about, having data, is how can we expand this data and apply in countries that are very different from where you're generating your data, like low and middle income countries? So will those come? You're going to have to adapt. How do you think it's going to work when you have your models?
That's true. You need minimal requirements for this. And this is true. This is limited now to those healthcare systems that have the data there, the data infrastructure for training algorithms. But I think in the future, this is going very fast. And I think in the future, if we are able to create a common data model, it will be easier in the future just to adopt a common data model, just as these are the data you need to collect prospectively. And then in a model like federated learning, you can just expand one arm to this different country. But I think it's a process. At least you need a reliable data integration that is reliable. Otherwise, you cannot apply this. You can just apply the results of the algorithm, but it's also tricky because this algorithm has not been trained in this population. You need to train the population that is going to be exposed to the algorithm to have reliable outputs.
That's great, Carlos. So we have a question for David about it. It's also a very pragmatic question, but it's asking how the video triage is being done. So it's a complex, diagnosis. We have a wide spectrum of differential diagnosis. How does it really work, David, when you are there in the ambulance? Can you describe it to us?
Yes, certainly, Gisele. So there are various platforms of video triage that are used in England, and the most common and earliest was just using simple FaceTime. Now, the average call duration is 6 minutes. I think that, in fact, most experienced clinicians, you probably know within 90 seconds, 2 minutes, whether you think this patient is having a significant stroke or not. It's also very helpful when it comes to patients with posterior circulatory events. There's no amount of grading systems that can be better than experienced clinical opinion. And so it is about the pathophysiology, understanding the epidemiology of stroke disease, and then the examination, which you can undertake with the patient in the back of the ambulance via the ambulance crew holding up their iPhone or whichever mobile phone they have, and you actually examine the patient, and you can pretty much accurately, within a few points, ascertain what the NIHSS is. So the benefit really is there, providing the clinician who is taking the call is competent. Now, one of the questions was, do they have to be a doctor? Well, what I would say is hopefully we've moved on from particular qualifications. It's about capabilities and competence. So if that individual would be seeing someone in the emergency department, making a diagnosis and sending them home, if they thought that was appropriate, they are capable of taking those calls. So in England, we have a mixed system where it's predominantly doctors, although there are some models where they're experienced nurses. Some have experienced advanced therapists that are taking the calls. What's really important is that this is not just a communication. This is not just an alert about someone coming. This is an examination, and this is a triage. And it's really important that we make the distinction between the two. And what it isn't for is just the difficult patients or the difficult cases. What we've found is not only can you make a better diagnosis, supporting the ambulance clinicians with this real-time video triage, you're also able to speed up the hospital processes. So if we take on average, looking at that mimic data, only 1 in 20 of the patients that arrive at your average emergency stroke centre in England is going to have an LVO. Now, that means that the 19 others, they might not need their CT, CTA, and their CTP in 3 minutes. They actually have a different process of care. They might need an MR because, in fact, it's very subtle. So being able to transform your workflow is one of the real benefits. And I've used this pre-hospital video triage for the last 5 years, and it really does change the way you coordinate your planned care when you think you've got somebody that clearly has a large bleed or an LVO. Everything can be very rapid, but of course you can't do that for every single patient, but you can pick the patient that has the very rapid intervention.
Yeah, it's very interesting to listen what you say, because I think that in stroke, because we deal with, process, we've been for years doing exactly the same thing from all patients, because we think that, we can do it faster if, we don't have to think. But, this can be this. Maybe it's not the right thing to do. Maybe you can be more individualized. We can have more individualized stroke care. Even thinking about costs. You don't have to do an MRI for everyone. You don't have to do a CTA and CTP for everyone. And I think that's what we've been doing for a while, just because it's quicker, just because you don't have to stop to think. Yeah. So I think that what you're saying, that we're probably going to a more individualized patient treatment. It's going to take a while. Yeah. So I think we are on a moving target right now. And I think that as patients, as our focus, we have a question from Tyria Richardson, who is a survivor from a bilateral cerebellum stroke. And I think that the question applies to the three of you. So she said that, it was said here that the symptoms were not easy to detect, even using the FAST criteria, because it's a posterior circulation stroke. So it's atypical. So the question is how AI models can be trained to recognize those subtle and non-traditional stroke signs, from posterior circulation, from cerebellar strokes, and to allow us to treat more patients. Do you want to start, Ona?
Well, my standard answer would be, get an MRI scan, and hopefully in the future of AI, improving the resolution of these images, maybe portable MRI systems can be utilized in the field to help speed up the diagnosis of these posterior circulation strokes. So I would say better imaging,
Yeah.
better technology.
Now, on top of that, I would say, besides better imaging, Also, facial recognition will make a difference. For instance, in your project, David, it's absolutely amazing. And the way it is the best way, the best scenario to test facial recognition softwares. So for someone to be, what if you don't have connection with the hospital, and you can just with an algorithm can detect this is a stroke, no stroke, LBO, no LBO, and activate the stroke code even for in the, far away future. Maybe you can, people can use this in the street when someone collapses, and you can see that it's an stroke by facial recognition. But a lot of things may happen, should happen in between. Legal issues, so ethics issues has to be solved for training facial recognition. But I think it's the future that is going to be beyond the human eye. This is really beyond the human eye's facial recognition. There are some promising results for some pilot study using facial recognition in ER that it can be clearly translated in the future in the pre-hospital setting.
And finally, Gisele, so I would agree. I think there's lots of opportunities for AI to help schedule our workflow. And I think that's the key thing, that autologous AI may well have a role at some point, but allowing us to spend the right amount of time at the right point in a patient journey. And when I say us, experienced clinicians, whatever their background, so that we get the right diagnosis as early as possible, is the future. I would say that one of the great things about the video triage project is we are more likely to pick up those patients with non-fast positive abnormalities that someone, either patient, relative, or ambulance team, is concerned about. And for those individuals that think, well, doesn't it not take a lot of your time? I would say to you that 6 minutes time invested right at the front, avoiding that patient coming to your front door, that saves so much time, because these patients are coming anyway. And to be able to reduce that number overall saves healthcare practitioners time. Thanks.
Well, thank you very much. It is great to finish this webinar with a patient's question, because that's why you're here for, to treat more patients and to make stroke prognosis better. So this webinar, that said, is recorded. And I really thank all the wonderful speakers and everyone who's here attending this session. Thank you so much, and we wait you in our next webinar. Have a great day.
Thanks, everyone.
Thanks.
Everyone.